First of all, thank you all for coming here this afternoon. I hope that I can deliver, an interesting talk for you guys. I'm Beatriz Carillo, and I'm part of the China Studies Center. I'm new to the university. I've been here for only a couple of months. My background is in doing work on welfare policy. I work also on issues around social inclusion here in China, inclusion and exclusion in China, and that's where this research, particular research on inequalities, actually fits in. Now, just two small caveats before I begin. I've just been at a 3-hour meeting, and that really did my head in. But hopefully that doesn't affect my performance here too much. Also, I realize that this setting is really obviously set up for very smart people who don't need their notes. But I need my notes, so I'm kind of going to stick to this particular spot, and the camera needs me here. So you'll see me sort of shuffling with my notes, so hopefully I won't need them too much. Okay, well let's get started. So often when we think about why individuals are sick or ill, we tend to think that it's actually the fault of their own behaviors. Okay, they smoke, they eat a lot of junk food, but of course they're unhealthy. If they did more exercise, if they eat healthier, they will be also healthier. And in fact, a lot of health campaigns target individual behaviors. Stop smoking, wash your hands, don't spit. The particular case of China, and this has been the case, for quite a long time here. But just for your own particular amusement, some posters back from the 1950s around sanitation and health campaigns that, as I said, targeted individual behaviors, people washing their hands, and people telling people not to spit on the street. More contemporary public health campaign would be again around spitting, would be the one in Shanghai, the 70-meter speed that was particularly targeted at rural migrant workers. But then we come across certain diseases or certain health damaging behaviors that seem to affect very specific social groups, very specific people, and that's where we're wondering whether there's something else other than just individual behavior that is actually affecting people's health. And just briefly, I'll give you a couple of examples just to illustrate this, and to sort of to get you into what I'm actually trying to get at. The first one is around child obesity in China. So recently there's been a rise of what we can call an obesity epidemic in China, particularly in urban China and amongst children. But the studies around child obesity in China have found that it is it's a condition that mainly affects boys of high socioeconomic status. So there already you've got an example of a whole range of factors that are sort of beyond the individual behavior that affect a certain group of people. Then the other more sort of straightforward one is around smoking rates. You're probably all aware that in rural China, more people smoke, as percentage of population, more people smoke there. And it is been linked to obviously less information being available about the damaging health effects of smoking, but also that people might not actually know about those negative health effects. So there's actually more people taking up smoking in the countryside than in the cities. So these two examples alone, give you some clues about the varieties of social determinants of health. So I mentioned socioeconomic status, gender, level of education, whether you live in a rural area or in an urban area, And all of these things have implications for people's health. And so I've been doing this kind of research for quite a few years, and I know that there's some quite dramatic statistics around health issues around the world. But there was a statistic, a health statistic that I heard of a few weeks ago that really shocked me, and I hadn't actually seen any data around that. And that was around suicide rates around the world, which really, for me, really sort of reinforced the idea that health is really in many ways the result of this broader social, economic, political context in which we live in, globalization, marketization, and so on and so forth. So I was listening to a lecture by an MIT professor who mentioned that in the year 2000, the number of people who committed suicide was double the amount of people who died at war during that year. So more people actually killed themselves, ended their own lives, than died in wars during the year 2000. So I looked up for some more recent statistics on suicide in the World Health Organization website, because as you know, they publish statistics around the leading causes of death every year. And for the latest that I could find was for 2012, when around 800,000 people around the world committed suicide. Many more tried to kill themselves but didn't succeed. So also this always allowed us to a mental health epidemic around the world. But what was even more surprising was to find that actually, even though suicide is not a leading cause of death sort of around all deaths around the world, among young people between 15 and 29 years of age, it is actually the second leading cause of death. So this is, this is huge. I think, that we always hear in the news, how many people are being killed in wars and so on, but we never hear, look, there's actually more people killing themselves. Why aren't we doing anything about this? But then, if you go further into the statistics, you find that, as you say, 75% of suicides happened in low and middle income countries. So again, socioeconomic development comes to the fore in trying to sort of explain or understand some of the health issues that affect people around the world. So as I said here, again, age, level of economic development, and probably some cultural and social stresses are also having an effect on this suicide epidemic. So seeing health as a social phenomena is obviously not a new approach. It's probably something that you had already come across and heard about. I mean, even Friedrich Engels, more than 200 years ago, one of the founding fathers of Marxism, of course, described exploitative class relations as the primary cause of premature mortality among England's working class. So there was already that Marxist analysis that said actually it's exploitative class relations that create bad health amongst this particular group of people, the working class of England, right? So, but then how do you explain, or how do you kind of tease out any causal relationships between the broader socio-economic and political system and the individual health of US citizens? And that, the relationships are very complex and very, very hard to actually explain and to map and to tease out. So most governments, the strategy of most government has been to just deal with health through health policy. Usually it means, more hospitals, better hospitals, training more doctors, getting, you know, better medical technology, new drugs and so on, and that should fix public health. But in fact, what we find is that a lot of public health issues remain and are kind of unsolved or continue to replicate themselves along this, you know, social hierarchy. I guess I should just kind of make a note that, you know, the issue is the inequalities that prevail within any socio-economic system. And those inequalities are actually at the root of health inequalities and health inequities. But inequalities per se are not necessarily either a bad thing or something that we can actually completely eliminate. But what I want to focus here on is the inequalities that then result in inequitable health outcomes. Okay, so that's, for the rest of my talk, I'll be concentrating primarily on, this is actually the World Health Organization's conceptual framework on action for the social determinants of health. In my talk, I'll be concentrating on the structural development, so the right-hand side of the chart. So I'm sorry to disappoint those of you who might be wanting to hear more about specific diseases or illnesses, but I'll be focusing more about, again, the broader structure that brings about inequalities that in turn bring about health inequalities and inequities. So the title of the talk was around urbanization and health inequality. So I guess I should say a little bit about urbanization and how urbanization actually causes health inequalities. So urbanization, both as a process and as a condition, are very strong factors affecting public health. Again, I had the quote from Friedrich Engels, who talked about, you know, the situation during the Industrial Revolution in England, and as you know, China has experienced one of the most rapid urban growths in the history of humanity, pretty much. And at the beginning of the economic reform strategy in the late 1970s, the reforms actually passed in 1978. The proportion of the population who lived in cities was actually very small, and very small compared to international standards. So China had actually, you know, during the whole Maoist period, really controlled the growth of cities. So as you can see here, only around, in the late 1970s, only around 17% of China's populations lived in cities. So that's actually very, very, very small. And the reason for that is that, as you know, in the cities, the work unit, the state-owned enterprise, actually provided, you know, this very generous set of welfare and of lifetime employment. So if you've got a very large population, well, you can't really afford to give that to everyone, at least not at an initial stage, so you need to control the growth of cities. So that 70% amounted to around 167 million people living in cities, and by 2012, that already had grown to more than 700 million. So this is the first time in China's history that more people live in cities than in the countryside. So throughout China's history, Chinese society had been primarily a rural society. But you know, if you think about it, you know, it's over 3 decades, so 30 years. It's not a very long time to add 500 million people to your urban system. That means, you know, you need to provide housing, you need to provide services to 500 million people. And that is, a massive. It's been a massive task, and of course, they've done really well, but there's still, great numbers of people who, again, the inequalities are there in terms of who gets, certain benefits. And in terms of, urbanization or the urban condition, shifting into an urban lifestyle, of course, involves a whole range of changes around, what we eat, the kind of physical activity that we do, and so on. So that also has implications for people's health. As you know, up to when you look at the breakdowns of the Chinese diet, even up to the late 1990s, China had, like, overall, both, if you take into account both rural and urban China had one of the healthiest diets around the world. They eat lots of vegetables and lots of grains, and the proportion of meat and sugars that Chinese were eating was actually very small, even smaller than the world average. But that has actually changed in the last decade and a half. You know that Chinese people are eating more and more meat on a per capita basis, and particularly more sugars. Now Chinese are getting in love with sugar like the rest of the world, which is not a very good thing for their health. Just another interesting statistic that I found is that China now eats about a quarter of all the meat produced in the world. So, on a per capita basis, it's still not the highest, but they're eating obviously more and more meat. But these, as I said, this urbanization affect different groups of people differently. Again, where in the social hierarchy do you see it? That's how you're going to experience the city. That's how you're going to experience urbanization, and that's how it's going to affect your health. So I'll talk a little bit more as to how those things work. So regional inequalities have been found to be one of the strongest determinants of individual health in China. Where you live really matters for your health if you're a Chinese person. The first example is a really stark example of how regional inequalities matter for health. These statistics for 2000, so they're not the latest, but already give you, that sense of how regional inequalities affect health. The differences in life expectancy between Shanghai, one of the most developed areas of cities in China, with Guizhou, a poor province in the south, more than 10-year difference in life expectancy within the same country. So that sort of just gives it, but not just around life expectancy. There are a whole range of health indicators. We see these kind of huge disparities. So, for example, here I just put infant and childhood mortality rates. The developed coastal areas, places like Shanghai, Beijing, and so on, are really on par with the developed world, with the rates in the developed world, whereas the less developed areas like Western China are actually facing rates 3 to 5 times greater. That gives you just a sense of the stark inequalities, stark regional inequalities that still prevail within China, and that really goes to the capacity of the local state, the local government, to be able to support these kind of services. I don't know if you know that China is really one of the most decentralized systems, political systems in the world. It really is almost like a federal system, even though not politically defined as such. But local states, local governments are really responsible for their own development, and if they don't have the resources, then all those services actually suffer. So here you see, the public spending. This is a World Bank report from 2003. Public spending by the richer counties. The county level is kind of like the lowest level of that administrative hierarchy, of that government hierarchy. So they're using that as a base. 48 times greater than that of the poorest counties. And this money goes to supporting health, education, infrastructure, and so on and so forth. So that already gives you, a sense of the quality of medical care, the kind of support that you can get through medical insurances in the different parts of China. Then, of course, also the health system itself and the ways in which it's changed since the introduction of the reform effort has, of course, had huge implications as well for people's health in the last over three decades. So what we've seen is that when the reform was introduced, it was first of all state-owned enterprises that were meant to sort of become more efficient, more profitable. They had to sort of shed some workers and so on. But this kind of principle was also introduced into the public sector, and including into public hospitals. So the government was asking public hospitals to sort of become more self-reliant. Government funding for health declined over time, particularly, actually up until the early 2000s, government funding for health consistently declined. And so hospitals were sort of kind of in a situation where if they wanted to keep their facilities running and if they wanted to pay, doctor salaries and so on, they had to be entrepreneurial as well. And so health started to be seen not just as a public good that needs to be, provided by government, but as a private good, that if you want good, medical care, you need to pay for it. And people started to accept that principle, which already, gives you a sense of also of the kind of value changes that were taking place within society with the introduction of marketization from the 1980s. But yes, the health system became to a certain extent more efficient, and they bought more newer medical equipment and so on. So there was a modernization process of the health system. But again, think regional inequalities, who did better, who did worse, and that would be reflected in how local health systems would be improved or not. But also that there was this reliance on fee for service. So if you want to make more money for our hospital to cover us, even to cover our own salaries as doctors, we need to prescribe more of the expensive medicines. We need to get people to go undergo all these procedures. I remember it probably would have been like late 1990s that I was in Shanxi, North China, with my then PhD supervisor, who was not feeling really well. He had a bit of a cold. He just needed some cold medicine, but we went to the hospital and the doctor prescribed him, he had to get an X-ray, he had to get blood tests, and we were thinking, this is really not necessary, but he had to go through the whole thing. So, and that became sort of a commonplace, to the point where, as it says here, that hospitals really depended on medicine sales to remain viable. That, you know, as the drug sales came up to as much as 60% of hospital revenue. And what I should say also is that in China, up to not that long ago, hospitals were also dispensing medicines. So it was kind of like a double business. No? So I prescribe you and I sell you the medicine. So it was kind of like, it was sort of logical that I ask you to buy my medicines because that's also my business. So now the government has actually separated the two. So what was happening was that basically access to health was being conditioned on individual capacity to pay for that treatment. And well, as you may probably be aware also that I didn't mention is that people were actually, you know, becoming very angry with doctors because they saw them as really greedy. They saw the whole thing as being, you know, the fault of doctors, that they're just greedy, they just want more money. But actually, it was more around, you know, the structural changes that were happening within the public health system that were pushing a lot of doctors to engage in this kind of behavior of asking for a hongbao, asking for a little bit of money to undergo, you know, to do some operation and so on. I mean, I'm sure that some doctors would take advantage of this, but obviously not the whole system would have been doing this. So there were actually, there's been quite a lot of cases of doctors being attacked by patients and by family or by relatives of patients. So here's just a photo of a protest by doctors and nurses to kind of protest this violence against them, you know, that they don't feel safe in their workplace anymore. So that leads me to income inequalities. So I said that, you know, now it really dependent on whether you have the money to afford medical care. So as China developed also, China was not an entirely equal society. There were some inequalities, you know, during the Maoist era. You know, we've got sometimes, you know, people get this idea that, you know, during the Maoist era everybody was the same. There were no inequalities. There were actually inequalities and some hierarchies, but they were perhaps not as stark as what we have here. Certainly not in income, because income, you know, money was not. It was not a monetarized economy in any way. But anyhow, inequalities have, socioeconomic inequalities and income inequalities in particular as well, have really grown, expanded. The gap has really expanded over the last 3 decades and 8. And so, again, as I said already, you know, healthcare, access to healthcare became dependent on whether or not you could pay for it. At the same time, what was happening was that the old welfare system that was attached to the state-owned enterprise, to the work unit, the downway, was being dismantled as well. So there was nothing, there was this in-between from the mid-1990s to the early 2000s where there was really no other social security system in place that people could enroll into. So you get a situation where health becomes more costly, but less and less people actually have medical insurance to cover their medical expenses. So the 2003 National Health Services Survey came up with some really shocking statistics that close to 50% of those who were surveyed did not seek treatment when ill, and that 30% of those who were actually referred to a hospital because they needed to be hospitalized, they refused this inpatient care because they could not afford it. So this was, you know, this was a really a big sort of warning sign to the Chinese government, and as you know, that the Ministry of Health actually acknowledged that health reform had been a failure. At the same time, I mean, I talked about rural-urban migration. Many of these people also were, many of these migrants were coming into the private sector or working informally, and they themselves, they too did not have access to any social insurances. So the labor and social insurance law was passed. The first one was passed in 1998, and that was kind of like the beginning of the formation of a new social insurance system, which really has only extended its coverage probably in the last 10 years. So there was still, a situation where, very few people had insurance, and less people were being able to afford care. Just before the 2009 new health policy was passed, the government actually ran an online survey asking people about, not just about health, but what were the main concerns that they had. And health was sort of ranked as one of the highest. So the government knew that it was high time to put more money into the health system. So in order to kind of like illustrate through kind of more like through the stories of individual groups, I'll share here just two examples of two social groups that whose health has actually suffered more, or they experience sort of more negative health effects from this whole process of urbanization and economic reform. And the first one is China's what I call here China's old urban working class. So this is the worker that that came of age during the Maoist era. Were probably born between the 30s and the 40s. They grew up during the Civil War, which would have also had an impact on their nutrition and their health. But nonetheless, they grew up and they worked in the state-owned enterprise. They had all the benefits of lifetime employment, or they were accustomed to lifetime employment. They thought that was going to be there for the rest of their lives. They were allocated housing. They had access to free medical care, free medical care for their dependents as well, and a whole range of other services that were provided through the downway. So you can see that obviously they had a very high sense of entitlement from the state. But when economic reform starts and the state-owned enterprise needs to be more economically efficient, well, obviously some people needed to go. Some people needed to let go. And so that's when enterprises are asking workers to retire early. And women were the first ones to be asked to retire early, or were the first ones also to be laid off. You need to have the men who are the real breadwinners, staying in their jobs. So this actually had serious negative health effects on this cohort of women who were then in their mid to late 40s, so to speak. Many of them would have also lost all of their entitlements, maybe even lost their pensions, because their factories were not doing very well. Some of them were, if their factories went bankrupt, then they didn't just lose their jobs, they lost, many lost their entitlements. But the other thing that needs to be taken into consideration was the whole experience of downward mobility, or social downward mobility for this group of people, where during the Maoist era they were always exalted. The working class was really the foundation of the Chinese economy, of socialist China. You were as an urban worker in the urban downway, you were part of that progressive social class. And suddenly you were part of a dispensable class, which the government didn't really care much about, or that's how it felt for a lot of these people. That suddenly well, sorry for your contribution during those, socialist years. Now we're in a different time, and you need to move out of the way. And there was initially there was actually nothing, no safety nets for these people. So, and in fact, a lot of studies on social determinants of health in China have found that women over the age of 55 are more likely to suffer from bad health. So this is again, an example of how age, gender, socioeconomic status, occupation, and region might have an implication on the health of a particular social group. The other one that you probably already heard about is the plight of rural migrant workers. Rural migrant workers constitute now, a really substantial proportion of the urban population. I told you that, urbanization in the last 30 years is really the result of movement from the countryside into the cities. And in fact, I don't know if I said this, but it's that migration movement since the early 1980s represents the largest population movement in human history. There's never been so many people moving from one place to another in human history ever. So it's a massive, I told you that 500 million people were added to the urban system. So these migrant workers hold a rural hookup, which do not entitle them to the benefits of that an urban citizen actually has. All the social insurance programs, even the welfare programs, the social assistance programs like the DIVAL, the minimum livelihood guarantee, can only be accessed if you've got an urban local hookup. So migrant workers are basically not included in all these social security schemes. Although some places have now instituted separate insurance programs for migrant workers, but these places are actually in the minority, and sometimes migrant workers actually don't want to join those schemes because the benefits are actually lower. Also, for migrant workers, something that more recent studies have started to show is that even though rural migrant workers are on average younger and healthier than the average urban population, they seem to experience higher rates of mental health problems, or at least at the same level of mental health rates of the urban population. And that it's been linked to this interpersonal discrimination that takes place in the city. So that social isolation, that stigmatization, migrant workers are described as being illiterate, or they're all criminals. They just want to steal your money if they can. They've got very low quality, and so that's how they're stigmatized, and that's the kind of interaction that they face on an everyday basis with the urban population, and that really has had an effect on their mental health. So I'm getting towards the end. But over these 30 years, more than 30 years of reform, giving all of these changes, the ideology and the policies have also changed as a result of that. So we started off from a kind of like a rejection of what were perceived as kind of like the ultra-leftist policies of Mao Zedong, to Deng Xiaoping saying inequality is actually something inevitable, Economic reform will bring about inequalities, but that's not something bad. You know, inequalities will mean that, you know, people will be more incentivized to do better, to innovate, to do more business and so on, and that will be good for everyone. But again, by the mid-1990s, well, inequalities had grown to a level that they were actually becoming problematic, and it was, you know, it was creating social dislocation. Social protest also increased since the late 1990s. The old working class that I talked about started to also turn up on the streets, and that's how actually the government reacted and brought about, you know, schemes to help them out. So you see a change with the coming of to power of Hu Jintao and Wen Jiabao. A shift in the political rhetoric from no longer say, you know, inequalities are now a problem. We need to address inequalities, and that's sort of like a, you know, a complete shift from the kind of rhetoric in the early 1980s. So now there's, you know, this move towards they're not talking about perhaps more explicitly about egalitarianism, but they are talking about this harmonious society, which obviously implies greater levels of equality, or at least diminished inequality. We've seen, you know, greater funding, government funding for health, but also for a whole range of other welfare programs. Although, as I said, you know, in general, this large chunk of the urban population is still not covered. That's those who have who hold a rural hukou. The latest policy is for the so-called rural-urban harmonization, in which, I don't know if you're aware that actually the social insurance schemes in the cities are different and separate from those existing in the rural areas. They're completely separate, and they actually offer very different benefits. So now the government's talking about harmonization, which is sort of intended to deal a little bit with the issue of what do we do with rural migrant workers. However, it seems like thus far, it seems like only, again, the richer provinces are being able to do that, because that involves, you know, a high level of redistribution of financial resources within the boundaries of provinces. So thus far, only, you know, a relatively wealthier parts of China have been able to initiate urban harmonization, and they're still living outside those who do not hold a hukou from that province. So there's different kinds of exclusions that are being created through these policies. So I hope through these examples I've given you a sense of how the inequalities created by the economic and political context are then really very much affecting health in China. And I've sort of come to my conclusions, and I think I will read them, and I will make it again more efficient as well. So I guess what I wanted to convey here today was that as a social phenomenon, health is a result not only of our material circumstances, of our behaviors, or of our genetic makeup, but that it is influenced by the broader socioeconomic and political context in which we live. That context, in turn, determines the socio-economic status of individuals and their health and well-being. So what I would argue is that only through the modification of those structural mechanisms beyond health policy can a society really build a more equitable health system and more equitable health outcomes for all of their citizens. And thank you very much for listening.